Hi guys, good afternoon. I hope all of you are doing well and if I'm audible and visible to all of you, then let me just know in the chat box so that we could start our session. Uh, Good afternoon, Mahalakshmi. Good afternoon, Alia. Yes, so I think the visual and the audio relays are going quite well. There's nothing to worry about at the moment. So today's discussion is going to be an image-based discussion where I will only and only discuss the images. There's no theory that I'm going to discuss in this session. It's going to be an exclusive image and diagnosis and maybe a couple of important points that could be necessary for your exams. So there are 104 images and we will discuss this in 1.5 hours to be very precise. It's like just giving 1 minute to that image, trying to recollect the answer, what is the diagnosis and go ahead, or maybe what's the image asking you for. We just want to identify that structure and go ahead. If that's okay with all of you, then kindly give me a thumbs up. Yes, there are questions on if I'm going to provide the PDF of this session. Yes, this annotated PDF will be uploaded on the app as well as on the YouTube comment section a few hours after the session is done. So you will get the annotated PDF as well. So nothing to worry about that. Yes. So I think, are we all ready? So the only one rule at the moment that I'd want all of you to know is, as soon as you see the image flashing on the screen, write down your diagnosis. As soon as you hear me asking you the question, write down the diagnosis. It could be just a short, short thing. Like for stapes, you can just write STA. You can, for malleus, write MAL. So you can write a short form of it. You don't need to write the entire thing. And so then we can quickly proceed with the next images. So yeah, so let's begin with the class. So this is the first image and we are having three important bones of the middle ear, and this is again a very important image based question asked to you. So can you all tell me what is this image 1, what is this image 2 and what is this image 3? Yes, so find out what are these images and quickly tell me what are these images. Yes, just give me a moment. My pen seems to be not connected or working. Just give me a second so that I can do it. This is a constant image-based question which has come in the recent exams. They can ask you individually ossicles like this. They can ask you an image-based question with a tympanic membrane perforation and also identify the ossicles, which we will do in the next slide. So in the current slide, I want you to quickly answer what is the answer for 1, 2, and 3. So 1 is nothing but your first ossicle, which is attached to the tympanic membrane, which we call it as the malleus. The second ossicle that you see here, where we have the malleus attached to the incus, malleus attached to the second ossicle, which is your incus, and the third ossicle is nothing but your stapes. So these three ossicles are very, very important. You should be able to identify these three ossicles. Not just the ossicles, you're supposed to identify through a perforation or through the tympanic membrane. How do you identify the ossicles? Always remember the ossicles are present in the posterior-superior quadrant of the tympanic membrane. So if we take this as a whole tympanic membrane, this is your anterior malleolar fold, which is the shorter fold. This is the longer fold, which is your posterior malleolar fold. So this is your anterior quadrant. This is the posterior quadrant. So where are you supposed to look for the ossicles? In the posterior quadrant. So the first ossicle that you see here, which is attached to the tympanic membrane, this is your handle of malleus. Then you will see that in the attic or epitympanum will be the head of malleus. This will be attached to the incus, which is again present in the epitympanum. And what you see here is the long process of incus. This long process of incus attaches to the head of the stapes. These are the crura and the footplate of stapes. So above the stapes, you see there's a nerve. So can you all quickly tell me what is this nerve that you see above the footplate of stapes in your chat box? This is what I'm interested in. So what is this structure? This is absolutely important for your exams. Yes, so I'm waiting for your answers and looking for the answers in the chat box. So quickly reply, what is this nerve that lies above the footplate of the stapes or the oval window? And this nerve is dehiscent in about 50% of the cases. There is a possibility of trauma to this nerve during mastoid surgeries and middle ear surgeries. So what nerve are we talking about? Yes, this is going to be your facial nerve. Somebody has written chorda tympani. Chorda tympani is not present in the middle ear. It travels through the tympanic membrane. Between the layers of the tympanic membrane, it goes from posterior to anterior quadrant, and it has no relation with the medial wall of the middle ear where we have the oval window and the foot plate of stapes. So what nerve are we looking at? This is your facial nerve. Right. So next, let's go to the next one. What is this image showing to you? This is a triangle used for identifying a particular structure when we are doing a mastoid surgery. So what is the name of the triangle and what are we going to access when we drill through this triangle? This is your question to all of you. Absolutely right, Nico, Raghav, absolutely right. This is nothing but your Mac-Evans triangle, and Mac-Evans triangle is a surface landmark for what? It is a surface landmark to identify mastoid antrum. So to identify the mastoid antrum, we are going to make a drilling in between the supramastoid crest. The second imaginary line is a line drawn through the posterior canal wall, and the third line is the tangential line. So if we make a opening in this triangle, what are we going to access? We're going to access the mastoid antrum. So that is done. Now let's go to this image and identify very, very important structures related to the mastoid. So as you all see here, this is your external auditory canal leading to the tympanic membrane, and medial to it would be your middle ear, and behind that what we see is your mastoid. So can you say what is structure 1? What is structure 2, and what will be the nerve present here at 3? So can you all quickly message this to me in the chat box? What is 1, what is 2, and what is 3? And of course, here we see a prominence, which is your 4. So what is 4? Yes, so what we have done here is called as a cortical mastoidectomy. I see so many of you are answering it, but not everyone is absolutely right. So 3 is something that everyone is answering. Sangeeta, absolutely right what you've written. The first one is your tegmen, which we also call it as the dural plate. So what do we call it as? Dural plate. That is our superior boundary where we have the supramastoid crest representing the tegmen. So if we go above it, we're going to probably go into the middle cranial fossa. The second one is the sinus plate, where we have got the sigmoid sinus. That is why you see this bluish color, because the sigmoid sinus will carry the venous blood. And the third structure that is labeled is your facial nerve. And this is very high priority structure that we take care of while doing mastoid surgery. It of course gives a branch here which is called as the chorda tympani nerve. Now the structure that you're seeing 4 is nothing but the prominence of your lateral semicircular canal. So when we are doing a mastoidectomy, as we approach and go deeper and deeper and deeper, if we see the lateral semicircular canal, then we know that we have reached the antrum. We have to not go any further, or any further drilling will only damage the inner ear. And now, very importantly, what is this angle between the dural plate superiorly and the sinus plate posteriorly? We call this as Sittelli's angle, also called as sinodural angle. So Sittelli's angle or sinodural angle is something that you should recognize. So this is a basic image of mastoid cavity, superior, inferior, anterior, posterior, medially lateral semicircular canal is something that you should know very well. The next image is asking you about what is this triangle. Can you all tell me what is this triangle where we have got the superior petrosal sinus superiorly, we have got this sigmoid sinus posteriorly, and we have got this solid angle medially. Solid angle is the angle between the 3 semicircular canal. So what is this triangle called as? I'm waiting for all of your answers. What is this triangle? Yes, I'm waiting for your answers, guys. So this triangle, we label it with something called as T. What is this triangle called as? Yes, this is called as Trotman's triangle, and this is the key entry to enter into the posterior cranial fossa. So if we want to go into the posterior cranial fossa, we go and drill through this bone between the superior petrosal sinus, sigmoid sinus, and solid angle anteriorly. Solid angle is the angle where all the 3 semicircular canals meet. Now quickly let's go to this image and identify what is image 1 and what is image 2. right? So what is image one? Which tympanic membrane, right or left, you should look at? And image two, what is it showing? Right or left tympanic membrane, you should look at and tell me. Yes, I'm waiting for your answers. Yes. So I see some of you have already started your reply. So one is the right tympanic membrane and two is the left tympanic membrane. That's all absolutely right. So the first thing that we look is cone of light. If the cone of light is present between 3 o'clock to 6 o'clock position, it is your right tympanic membrane. But if it is present between 6 o'clock to 9 o'clock position, then it is your left tympanic membrane. So we already know this. Now let's go to the next image. As soon as you see this image, there is a striking image that gives you a particular diagnosis. I'm not going to explain detail about anything. This is something that I've told you prior in the beginning of the class because this is a quick image-based recall. See the image, give me the diagnosis. You're seeing something, the tympanic membrane is red, the blood vessels are radiating from periphery to center. There's also a spot which is bulging, probably having pus behind it. So what is it? Yes. So as soon as you see this image, your diagnosis has to be very clear, ASOM, and in your head, you should be able to recall what is the causative organism, what is the symptoms of ASOM, in which age group do you see, what is the mainstay of therapy, whether it is medical or surgical, and surgical myringotomy is done in which four indications. If you're able to recollect all of this much, it's more than enough. So we will go to the next question, and I'll ask you, what does this image show to you? Yes, an absolutely simple, easy image which has been given to you multiple times, even in the recent exams, where you see the tympanic membrane is not red, it is dull, it is pale. You can see something very specific here. You see some air bubbles, air-filled cavities over here, right? So presence of air bubbles. And if you see here, there's a dark column below and a light column above, which means that there is a fluid level below and there is an air level above. So this air fluid level is diagnostic of a particular condition. Yes, very good. This is nothing but glue ear, also called as serous otitis media, also called as secretory otitis media, also called as otitis media with effusion. Now they can club this glue ear with a JNA question and ask you that unilateral SOM in a juvenile age group with epistaxis. They can give you and ask you a question on those lines. They can ask you a question on NPC, whether there's a patient having nasopharyngeal cancer, weight loss, history of smoking, and now presenting to you with unilateral hearing loss and a dull tympanic membrane with air fluid level. You should get to the diagnosis of NPC. They can ask you simply adenoid hypertrophy and glue ear and ask you treatment of choice. What is the next best step in the management? So these are the lines of question which have been asked in the recent exam. So if you're able to recollect all of that, superb. Now let's go to the next image and identify, first of all, what is the eardrum? Is it the right tympanic membrane or the left tympanic membrane? So first answer this, right or left. Second question to all of you is, what is the type of perforation that you see here? The third question too is, what is structure 1, structure 2, structure 3, structure 4, structure 5, structure 6? So go on labeling all of these structures. Yes, all of you have written it as left tympanic membrane. It is absolutely right, because even if you don't see cone of light, you see this is the shorter fold called as the anterior malleolar fold. And if the cone of light had to be, it would be somewhere here between 6 to 9 o'clock position, which means that this is the left tympanic membrane. So that everybody has got it right. Now we see that the perforation is in pars tensa. Do you see that the perforation is localized only to the pars tensa? It is not present in the pars flaccida. So whenever we have a perforation occupying all the quadrants of pars tensa and the annulus, see here, the annulus is not involved by the perforation, then we call such a perforation as subtotal perforation. So what would we call this as? This is a subtotal perforation. Okay, now when we know that this is a subtotal perforation, now we need to identify structures. What is structure 1? It is nothing but your handle of malleus, which we've already discussed, nothing new. What is structure 2? It is the long process of incus, right? That's also done. What is structure 3? It is your stapes. Okay, what is your structure 4? Structure 4 is nothing but your round window. So what you see here, this is your round window, and above that we have got structure 5, which is showing to you the oval window. What we see here, structure 6 is the anterior part where we have the opening of the eustachian tube. So we know anteriorly we have the opening of eustachian tube, posterior superiorly we have the ossicles, and posterior superiorly will be your oval window, posterior inferiorly will be your round window. We are not able to visualize the facial nerve very clearly, but if it had to be, it would be somewhere here. So this is the location or the region where the facial nerve possibly would have been in the middle ear. Now, if we would have a perforation here in the pars flaccida, what would we call this as? Any perforation in the pars flaccida would be called as? Yes, attic perforation, right? So happy baseball. So what is umbo? The point where the tip of handle of malleus attaches to the tympanic membrane, we call it as umbo. But since umbo is not visible because the tympanic membrane is perforated, right? So I think this part is clear. And whenever we have a perforation in the pars tensa, is it a safe type of CSOM or an unsafe type of CSOM? Definitely, it is going to be the safe type of CSOM, which is also called as tubotympanic type of disease. Right, so we've revised most important things. Now let's go to this image. Here they're just showing to you that there is a whitish mass behind an intact tympanic membrane in a child, no prior history of ear disease, no prior history of any ear surgery or any ear discharge. So what do you think it is? Very, very good. I see all of you answering it absolutely right. It's nothing but your congenital cholesteatoma. So this is an image of congenital cholesteatoma. And the criteria that we call it is called Levinson's criteria for congenital cholesteatoma, which we've already revised. So we go ahead into the next image. So look at this image and tell me, where is the disease? Is it located in the pars tensa or is it located in the pars flaccida? And also, do you see that the pars flaccida is intact or is it retracted? And do you see inside the pars flaccida there are some whitish keratinous flakes? Yes. So here what we see is a pars flaccida retraction. And we see that within them is the keratin flakes. So whenever we have a pars flaccida retraction with keratin flakes within it, we think of acquired cholesteatoma. So this image should prompt you to the diagnosis of acquired cholesteatoma. Now we have, for identifying the retraction and its grades, we have classification. So for pars flaccida, the name given is, anybody can tell me what is the name for pars flaccida retraction? Classification. And for pars tensa retraction, what is the name of classification system? Quickly. So for pars flaccida, we have called it as the TOS classification. And for pars tensa, we call it as SAIDS classification. It's not very difficult, very simple, not asked very frequently, but just be familiar with the words, right? Okay. Now let's go to the next image. Am I okay with the speed or you want me to slow down? Let me know in the chat box, because the whole intent is to help you identify the image and get to the most important points. So if the pace is fine, we go in this pace and we finish it off very quickly. So quickly tell me if all is okay with all of you. Yes. You're seeing here multiple perforations. Very good. I see all of you are jumping to the diagnosis very quickly, which means that it's all going fine. Right. So when you see multiple perforations, it is tubercular otitis media. My question to all of you, is it painful or is it painless? This is the very important clue that will be given to you in the exam. So answer this question, painful or painless. And how is the hearing loss? Is it nice? I mean, is it less or is it more? That is my question to all of you. Yes, it is painless and the hearing loss is more than what we could expect as per the extent of disease. So there is a disproportionate hearing loss. And sometimes they can also give you the word pale granulations. So whenever you see pale granulations in the middle ear, you should think about tubercular otitis media, right? Okay. Now let's see this image where you see that there is a flamingo pink appearance of the tympanic membrane, of the promontory, seen through the intact tympanic membrane. What would you call this? Flamingo pink appearance. They'll give you female, they'll give you age 30 to 40 years. They'll tell you gradually progressive conductive hearing loss. They will tell you this increased after pregnancy or after menopause. And they will ask you, what is the Diagnosis. So you should be able to tell me the diagnosis. Yes, so many of you have written glomus. See, in glomus, we see that rising sun appearance. This is a flamingo pink appearance of the promontory seen through an intact tympanic membrane, and we call that sign as Schwartz sign. And where do we see this Schwartz sign? The Schwartz sign is seen in otosclerosis. So again, otosclerosis is a very, very important question. They can give you Schwartz sign, they can give you audiometry, they can give you tuning fork test, and they can ask you questions on this, right? Treatment, again, it's no sodium fluoride is given only if the Schwartz sign is positive and there is an active focus. If it is positive, it means that there is an active ongoing disease, then you can give sodium fluoride. Otherwise, you don't give sodium fluoride in an inactive disease. Okay, then the treatment is either hearing aid or surgery. Surgery is stapedectomy or stepidotomy with placement of prosthesis. So this is something that you should know. Right now, look at this image, and what do you see? There is a reddish hue coming from the floor of the middle ear. It's not pinkish, it is bright red. What do you think? What is the diagnosis? Giving you this appearance, which is called as rising sun appearance. And what should your answer be? Yes, this is nothing but your glomus tumor or glomus jugulaire, which appears from the jugular bulb present in the floor of the middle ear. And whenever they give you this image, they can also give you brown sign, which is on seagulization and increasing the pressure in the external auditory canal. The mass vibrates vigorously and the red mass becomes pale. That sign, we call it as brown sign. They can ask you another clinical sign, which is called as aquino sign, where applying pressure on the carotid makes the mass pale. That is called as aquino sign. These two are your clinical signs. Okay, otoscopy is also clinical signs. They can ask you what is the radiological sign as well. So radiologically, you should know that there is a sign which image is there in the coming class, which is the Phelps sign. And then you have got on an MRI, salt and pepper appearance. So very importantly, Phelps sign is seen on a CECT, whereas salt and pepper appearance is seen on an MRI. This is something that you should know. Very importantly, glomus will secrete catecholamine. So catecholamine excess is something that you should expect in glomus. So they'll have headache, tachycardia, palpitation, all of those symptoms. And you have to check the catecholamine levels prior to the surgery. The investigation of choice, all of you should be able to recollect, that is contrast enhanced CT scan. You have to treat it by embolization first and then doing a surgical excision. So I think that's all done. Now let's go to the next image. They can give you an image where you see there is a blood in the canal. The tympanic membrane has perforated and the remnant tympanic membrane is reflected outwards in the canal. So the flap is reflected outwards. So what do you think is the diagnosis? There's a history of fall. There's a history of trauma. After this, they have given you this image. So Fatima, glomus types and how to differentiate. Mainly you have to know about glomus tympanicum and glomus jugulaire. When they give you an image for glomus, they typically will give you for image of glomus jugulaire only. Even if they give you glomus tympanicum, you will see a red image, a red reflex seen through the tympanic membrane, not a pinkish reflex. So a red image that is seen through the tympanic membrane with a history of catecholamine excess or with a history of pain or with a history of bleeding or pulsatile tinnitus, all of that should prompt you about glomus. Now, between tympanicum and jugular, the location is different, but rest of the symptoms and signs would remain the same. Yes. So this is nothing but the traumatic perforation. So whenever there's a trauma, the tympanic membrane perforates and the flap or the remnant tympanic membrane will get reflected outwards and you will see blood in the canal. They can ask you for traumatic tympanic membrane perforation. This was asked even in the recent exam. What is the treatment of choice? Would you do myringoplasty? Would you do tympanoplasty? Would you wait and watch, or would you ask the patient to take some ear drops and come back to you for follow-up? What would you do? I'm asking you this question because this was a repeat asked in the last few exams, so you need to know about this. So for a traumatic perforation of the tympanic membrane, what will you do? Yes, you're going to wait and watch, but for how long? How long? There has to be a time limit, right? So 4 to 6 weeks, you're going to wait and watch. If after 4 to 6 weeks, the tympanic membrane does not heal by itself, then you're going to do a myringoplasty or a tympanoplasty, depending upon the middle ear status. Okay. And very importantly, you have to make sure that keep ear dry. and no eardrops. In traumatic perforation, we don't even instill eardrops unless there is a sign of infection. So no eardrops, no water should enter into the ear, and the ear has to be absolutely right. Okay. The next image. Okay, so I think I'm not supposed to write on the right side corner, so I'll skip doing that. I was missing it. I was just looking into the comments all this while. Great. So look at this image and tell me, it's very, very important image that they can ask you in the exam. You see that the skin over the mastoid is shiny, red, tensed, which we call it as ironed out appearance of the mastoid. What is happening to the pinna? It is being pushed outwards and forwards. Yes. And ironed out appearance is the first sign that we see in acute mastoiditis, right? So in acute mastoiditis, this is the first sign that we see. Yes. Clinically, what are the other signs that we see? We see lighthouse sign with the pus is discharging constantly in a pulsatile format, reflecting light. And the most specific signs, these are the questions that will come to you. First sign and specific sign. Specific sign is your reservoir sign. So what is reservoir sign? On mopping the pus, you'll see that there is immediate reappearance in mastoiditis. But if it is ASOM, you won't see immediate reappearance of pus. So I'm sure all of you are done with this. Let's go to the next image. After mastoiditis, a patient developed a swelling below the mastoid. You can see this is the mastoid bone. A muscle is attached to the mastoid and there is a abscess in this muscle. So can you all tell me what is the name of this abscess? Yes, very, very good. All of you are right. This is nothing but your Bezold's abscess, which is an abscess in which muscle? Sternocleidomastoid muscle. Now, if they would have given you an abscess here, behind the pinna, then what would it be? Then what would it be? This is the most common complication after mastoiditis. What would we call it as? It is nothing but your post-auricular abscess. If they would have given you a pus here in the external auditory meatus, then what would you call it as? You would call it as lux abscess. And if they would have given you pus here near the posterior belly of digastric, what would you call it as? Yes, you would call it as Citelli's abscess. Okay, so Citelli's abscess is digastric abscess, lux abscess is meatal abscess, Bezold's abscess is nothing but your abscess in the sternocleidomastoid muscle, and the most common one is your post-auricular abscess. So now let's do the next image. Can you all tell me what is this sign? This is a complication following CSOM where you see that there is edema and bluish discoloration of the mastoid. So whenever you see that there is edema and bluish discoloration, what should you think of? Yes, most of you are telling me it's battle sign. I'm telling you, right, it could be battle sign, but I'm telling you this is a complication of CSOM. Do you see battle sign as a complication of CSOM? Is it a complication? No. So what is this sign which is following a complication of CSOM where there is edema and there is bluish discoloration? Yes, this is because of lateral sinus thrombosis or sigmoid sinus thrombosis, and we call this sign as Greisinger's sign. This is because of thrombosis of mastoid emissary veins. So we have got the mastoid emissary veins, right? Because of those thrombosis, we are going to get this sign, right? So this is a clinical sign following CSOM complication. A similar complication sign can be seen following trauma or middle cranial fossa. So if they would give you trauma or a MCF, middle cranial fossa fracture, then if you would answer battle, I'll agree. But if the clinical description is that of CSOM, then go with sigmoid sinus thrombosis. Now look at this image and tell me what is the answer. Very important. 6 o'clock English class. Okay. Yes, so if this is an image given to you following CSOM, there is a complication. CSOM complication is resulting to you in a double ring sign. What should that double ring sign indicate to you? Yes, this is an indication that there is a temporal lobe abscess. Now, can this abscess also happen in the cerebellum following CSOM? Yes, it can happen, but the most common is the temporal lobe abscess. And how do you identify? By this double ring sign, where there's a central hypodense area surrounding by an enhancing ring that prompts to you that this is a temporal lobe abscess, which is again a previous year question. Now let's go to the next image, where you see that there is redness and inflammation of the entire pinna, where there is sparing of lobule. What is your answer? Whenever there is sparing of lobule and you see that there is entire pinna is red. Yes, I'm waiting for your answers. Yes, this is nothing but your perichondritis. See, where do you have cartilage in your lobule of the ear? No, but the rest of the pinna has this elastic cartilage. So whenever there is in redness of the entire pinna with sparing of the lobule, you should think that there is inflammation of the cartilage, which is why the lobule is spared. So the answer is nothing but the perichondritis. Right? Okay. Now let's go to this image, which was again an image asked in the recent examination of the INI-CET or FMGE. I don't remember, but one of the examination, this was an image that was asked to you. So can you tell me what is this image showing to you? As soon as you see this image, something should prompt to you. What is it? Foodie, it is the type of hearing aid for sure, beta. But tell me what type of hearing rehabilitation device. It is done for children who are bilaterally having profound, meaning more than 90 decibel hearing loss. In those patients, we do this. Yes, very good, Javed. It's a Stenver's view, modified Stenver's view, and this is done for patients who are bilaterally having profound hearing loss. This we call it as a cochlear implant. This cochlear implant surgery will have two components. This is an external component, and this is an internal receiver. From the internal receiver, we have an electrode array. This electrode array goes into the cochlea, and you can see that it is making turn inside the cochlea. This is the ground electrode. What is this? This is the ground electrode, so as to maintain good electrical function within the electrode that is transmitting the impulses to the inner ear. So this is the internal receiver, this is the external microphone, and this is your electrode array. This electrode array goes into the inner ear, and you have a ground electrode to control the electrical impulses. So I'm sure all of you got this cochlear implant image. Now look at this image and tell me what is this image showing to you. Very quick, very easy. Yes, so quickly tell me, what is this image showing to you? There is a titanium screw, and this titanium screw is integrated with the skull. And over the titanium screw, you have got an abutment, and over that we have placed the processor. Now, what will happen? The processor will receive the sound impulses and transmit the sound impulses directly to the cochlea, bypassing your external ear and the middle ear. Yes. So what is this implant called as? Very, very good. This is called as BAHA, bone anchored hearing aid. I just want to give you two important points here to remember. BAHA is used in which two conditions? The first condition you should remember is whenever there is a congenital abnormality of the external auditory canal or the pinna, like, atrasia, oral atrasia, external auditory canal atrasia, anosia, microtia, and there you can't use a hearing aid, then you're going to go for BAHA. Second one is unilateral profound SNHL. If there is a bilateral profound SNHL, we learned that the indication is CI, cochlear implant. But if it is unilateral, not bilateral, then you go for BAHA. Right? These two, if you remember, I think it's enough. The rest of the thing is not so important. So remember these two very important indications for BAHA. Now look at this image and tell me what is being done in this patient. The patient is made to sit, and then the head is turned, and after the head is turned, the patient is made to lie down. And now what is it that you see? Yes, this is done for BPPV, benign paroxysmal positional vertigo. And this BPPV, benign paroxysmal positional vertigo, the maneuver for diagnosis, the diagnostic maneuver is called as Dix-Hallpike maneuver. Okay, what is it called as? Dix-Hallpike maneuver. And the treatment maneuver is called as Epley's maneuver. So what do we call it as? Dix-Hallpike and Epley's maneuver. Right? So I think this part is clear. Now look at this image and tell me what is it. Again, very important image where you can get a lot of questions. You see that there is a wet newspaper appearance. There is whitish spores. There's a blackish spores and whitish discharge. And this is because of a fungal infection, which is commonly Aspergillus niger and Aspergillus fumigatus. And now what is the diagnosis? Very good. This is nothing but otomycosis, which is the fungal infection. Look at this image. You're seeing vesicles in the area of distribution of the facial nerve, and you're seeing that there is an element type of facial palsy. So element type of facial palsy, but along with vesicles in the area of distribution of facial nerve, and if they have SNHL, sensory neural hearing loss, what do you think is the answer? Yes, the answer is nothing but Ramsay-Hunt syndrome, also called as herpes zoster oticus. For Ramsay-Hunt syndrome or herpes zoster oticus, how is the prognosis? I want you to just remember this. Rest of it, you'll remember all of the things. I just want you to answer, how is the prognosis? Is the prognosis good or bad? That's my question to all of you. How is the prognosis here? Prognosis is good or bad? Remember, Bell's palsy has a good prognosis, but Ramsay-Hunt syndrome has a bad prognosis, not so good prognosis. Okay, so remember that this can come as a part of the MCQ, where it could be an option that Ramsay-Hunt syndrome has a very good prognosis. No, it has got a guarded prognosis or it has got a bad prognosis. And Bell's palsy has almost 90 to 95% of recovery rate spontaneously, but that's not the case with Ramsay-Hunt syndrome, right? So I hope this point is clarified to all of you. Now look at this image and tell me your diagnosis. As soon as you see this image and audiogram, you should tell me, first of all, is this a right ear audiogram or a left ear audiogram? What does this less than symbol indicate to you? Is this an AC curve or BC curve? What does 0 indicate to you? Is this an AC curve or a BC curve? Yes. So first of all, because the signs are given to you in red color, it is the right tympanic membrane. So that's your answer. Then less than symbol. Okay, so less than symbol indicates to you bone conduction of the right ear. So it's not the air conduction, it's the bone conduction. So bone conduction of right ear, is it in the normal range of 0 to 20? Yes. But what about the air conduction, which is indicated by 0? Air conduction is not in the normal range. It has gone down or it is abnormal. So AC abnormal, BC normal, and there is an airborne gap, right? Whenever you have this, what is the diagnosis? It is going to be your conductive hearing loss. Got it? Yes. Now look at this image. Tell me quickly. Right ear, we know because the color coding is red. 0 is nothing but air conduction of the right ear. Less than is nothing but bone conduction of the right ear. Are they in the normal range of 0 to 20? No, both the curves have shifted down. So AC abnormal, BC abnormal. And do you see that there is a gap between the two that's more than 20 decibels? No. So AC and BC abnormal with no airborne gap or gap less than 20 decibel. Then we say that the diagnosis is what? Sensory neural hearing loss. So the diagnosis here is right SNHL. Now look at this graph. Is this right ear or left ear graph? Yes, quick. This is a left ear graph because the if given image is showing to you the color coding with blue. So this is the left ear. X is for air conduction of the left ear and closed bracket is for bone conduction of the left ear. So AC and BC both are in the abnormal range and there is no airborne gap. And the gap is less than 20 decibels between the two frequencies. And you see that there is a down sloping type, meaning with every frequency that we are increasing, the hearing loss is only increasing. So when you see a down sloping pattern, what should you think of? Very good. Answer is presbyacusis. Right. So the answer here is presbyacusis. But if the reverse was given instead of downsloping, if upsloping was given to you, then what would you answer it as? Upsloping type of a graph is suggestive to you of what? Yes, it is suggestive to you of Meniere's disease. Yes. So I hope all of you got it. Now let's go to this image. Now when you see this image, what do you see here? This is a right ear graph where open bracket is telling to you about bone conduction. 0 is talking to you about air conduction. BC is in the normal range. AC is in the abnormal range. There is an AB gap present. Airborne gap is present. And you see something specific. At 2000 hertz, there is a dip in the BC curve. So what is that conductive hearing loss? Where there is a dip in 2000 hertz, we call this as Carhart's notch. And Carhart's notch is seen in which condition? It is seen in otosclerosis, right? Now let's go to this image. What do you see here? What do you see here? 0 indicates AC, lesser than indicates BC. AC and BC are abnormal and there is an airborne gap. And what do you see here? If AC, BC both are abnormal, you're thinking of SNHL. But there's something that is strikingly showing to you. At 4000 hertz, there is a dip in AC and BC. What will you call this as? You will call this as Boiler's notch. And where do you see this Boiler's notch? You see this Boiler's notch in noise-induced hearing loss. Right? So that's done. Now look at this image 1 and image 2 and tell me what are the investigations being done in these children. What is image 1 showing? What is image 2 showing? Which one is otoacoustic emission and which one is Bera? Yes. So image 1, see the child is awake. Image 2, the child is sleeping, right? Look at image 1. Are there multiple electrodes or only a handheld device showing to you that present or absent? This is the only inference giving. Here you see multiple electrodes connected and they are giving you 7 waves, right? So the first one is nothing but otoacoustic emission. The second image that you see is nothing but your Bera. So I hope everyone got this otoacoustic emission and Bera. Yes. Now let's go to the next image and let's see what are the diagnoses here. So you see here medially there is a bone. What is this bone? Septum. That's labeled for you. That is the midline. What is this lateral wall? What is image? What is the label 1 and label 2 showing to you? These are not polyps. These are normal swellings which are present in the lateral wall of the nose, which are called as projections, also called as concha. So 1 is nothing but your inferior turbinate. 2 is nothing but your middle turbinate. Right? So we have the inferior turbinate and we have the middle turbinate. So clear with everybody? Yes. Below the turbinates, we have the meatus. So what we saw here, this is the right nasal cavity and what we are seeing here is the left nasal cavity. So if we see the left nasal cavity inside picture, what are we seeing? This is nothing but your septum. Okay. This is nothing but your inferior turbinate. This is nothing but your middle turbinate. Got it? So we have the septum, we have the inferior turbinate, middle turbinate. This is the floor and we cannot see the roof or the superior turbinate at the moment in this endoscopic image. Okay. So now let's go to the next image. What is the next image showing to you? Very simple, easy question where they're showing to you that there is hypertrophy of the sebaceous glands in alcoholics and diabetics. What do you call this as? Yes, very easy. This was an image given in one of the exams, INI-CET. Very simple, quick to recall. What is the treatment of choice? You're going to do the laser debridement of the hypertrophic sebaceous glands that is present. Okay, that's all that you're going to remember here. What is it that you're seeing? This is a speculum examination showing to you that the bone in the midline is bent. What do you call this as? We call this as deviated nasal septum. Okay, so this is nothing but your deviated nasal septum. Now, if I give you an image and I ask you about the incisions, okay, so if I make an incision at the caudal border of the septum, at the mucocutaneous junction, just there, if I make an incision for septal correction, what is that incision called? And if I make an incision about 3 to 5 mm behind it, what will I call that as? So the one that we do at the caudal margin of the septum, this is called as Killian's incision. The one that is done behind is called as Freer's incision. Okay. So everyone got it? Killian's incision is done on the caudal margin of the septum, whereas Freer's is a little behind, 3 to 5 mm behind the caudal border of the septum. Okay. Now, this was again an INI-CET question where they asked you about this image showing to you that there's a blackish discoloration under the eyes. The patient is constantly rubbing the nose. What is the sign called as? And there is a dark line that is present on the dorsum of the nose. What do you call this as? Yes, the first one that you see here, where there is a blackish discoloration under the eyes, we call this as allergic salute. Then you see, because the patient is constantly rubbing the nose, we call this as salute sign. And this sign where there is a blackish discoloration on the dorsum of the nose, we call this line as Darier's line. So this is nothing but allergic shiners. This is nothing but your allergic salute. And this sign is called as Darier's line. So they can ask you questions on these images as well. Now look at this image and tell me what is your diagnosis. There is a swelling that is present over the frontal bone, but it is black on CT. So do you think it is air-filled or is it mucus-filled? This is not Pott's puffy tumor. Pott's puffy tumor is osteomyelitis of the frontal bone, secondary to sinusitis. So when we see sinusitis, there has to be either mucosal thickening, either there has to be secretion, something should be present. But none of that is present. So is this air-filled swelling or is this a sinus-filled? Yes, so this is an air-filled swelling. We call this as pneumatocele. Okay, if it was filled with mucus, mucocele. If it was filled with pus, pyocele. And if it is air-filled, we call it as pneumatocele. Again, a question that's a standard question asked multiple times in the exam. What do you think is the diagnosis? A red fleshy mass that is present in the nose. And you see that here there are sporangia with spores. So when you have sporangia and you have spores on histopathology, red fleshy mass, what should you think of? Yes, rhinosporidiosis. Can you tell me, is it caused by bacteria, virus, fungus? What is it? What is rhinosporidiosis caused by? Yes, I'm waiting for your answers. Yes, rhinosporidiosis is caused by an aquatic protozoan, which is called as Rhinosporidium seaberry. This protozoa is endemic in South India. It produces a red fleshy mass and it is vascular, so it presents to you with bleeding. And the treatment for rhinosporidiosis is excision of the mass and cauterization of the base. Now look at this image. You see a nodule that is present on the dorsum of the nose. It looks woody, hard, firm in consistency. What could be the diagnosis? On histopathology, you see Mikulicz cells and you see Russell bodies. What should be the diagnosis here? You see a firm nodule, which is called as a woody, hard nodule. Yes, this is nothing but rhinoscleroma. Rhinoscleroma is caused by a gram-negative bacteria, which is called as Klebsiella rhinoscleromatis, also called as Frisch bacillus. This is endemic in northern part of India. This is treated medically with streptomycin, tetracycline, and rifampicin. After treatment, we also do debridement of the dead tissue. And we stop the treatment only when 2 subsequent cultures are negative, then only we stop the treatment. Yes. Now look at this image and tell me what is it that you see here. There is a nodule on the tip of the nose, and when you apply pressure, it will blanch. It resembles or it is given a fruit's name. What is it called as? Very good, Shadi. This is called as apple jelly nodules. Apple jelly nodules are seen in which condition? This is seen in lupus vulgaris. And what is lupus vulgaris? It is a low-grade tubercular infection that can be present. There is no active pulmonary disease. There are no active symptoms present in the patients. The treatment is again going to be anti-tubercular therapy only. Look at this image and tell me. You're seeing greenish color crust. You're going to have wide roomy nasal cavity. These will be your keywords. So wide roomy nasal cavities. There is going to be greenish crust inside the nose. It is usually seen in women. What is the answer? Yes, atrophic rhinitis. This is the answer. But if they give you a question where you see greenish color crust limited only to the anterior 1/3 of the nose, it's not present in the entire nose, it's only in the anterior 1/3 of the nose, then will your answer be atrophic rhinitis or will it change? This is seen in patients who are bakers by profession exposed to hot, humid environment. Then what will your answer be? Then your answer has to change to rhinitis sicca. Okay, so rhinitis sicca is a condition where because of constant exposure to hot, humid air, like in bakers or miners, because they inhale warm air constantly, only the anterior one-third of the nose will have crust, rest of the nose will be fine. Okay, so I think that is sorted. Let's look at this sign. Again, a very important image. They have given this image multiple times. What is this image? Following trauma, you see that there is a double ring appearance. You see that there are two rings. There is an internal ring and there is an external ring. So what will you call this sign as when there are two rings? Yes, we call this as target sign, also called as double ring sign, which is seen in a patient with traumatic CSF rhinorrhea. So if I ask you a question that what is the investigation of choice for traumatic CSF rhinorrhea? What should your answer be? What investigation will surely tell me that this is CSF and this is not other nasal fluid? Which investigation will tell me that? Yes, it is beta-2 transferrin. Okay, so somebody is told CECT, CT cisterno nico. Answer is not that. Investigation of choice will be beta-2 transferrin. To identify the active site of leak, then you're going to do a CT cisternography, meaning from where is it leaking in the base of skull, then you're going to write CT cisternography. Okay. But to identify it is CSF or not, beta-2 transferrin or beta trace protein should be the investigation of choice. Now look at this image. You see on one end, this part of the posterior part of the nose is open, but the other part or the other side is closed. What is this condition? It is associated with charge syndrome. What is it? We're discussing a congenital abnormality of the nose where the patients will have persistence of a bucconasal membrane resulting in a condition which we call it as choanal atresia. So choanal atresia is a condition where there is persistence of bucconasal membrane or fusion of the bones in the posterior part of the nose, because of which the nose cannot communicate with nasopharynx. It is associated with charge syndrome, where C is for coloboma iridis, H is for heart defects, A is for atresia, R is for retardation, G is for genital abnormalities, and E is for ear abnormalities. Okay. And very importantly, what is the immediate treatment of choice for a bilateral choanal atresia? You put a nipple which is called as McGovern's nipple, and that technique is called as McGovern's technique, which is asked in the recent exams. Okay. Now look at this. This was also an image given in the recent exam. Following a trauma, patient presented to you with headache and there was a swelling that was gradually increasing in size and that caused proptosis. What do you think is the answer? The drainage of the sinus is blocked. As a result, there is a bag of mucus that is getting accumulated, gradually increasing and increasing and increasing in size. What is it? What is your diagnosis? Now, usually following sinusitis, we see this complication, but when there's a trauma to the face, then also you can have inflammation. Inflammation can cause narrowing and stenosis. And because of inflammation and stenosis, the mucus gets trapped within the sinus, which is having the complex drainage pathway, which is nothing but your frontal sinus. And once the mucus gets trapped within your frontal sinus, it is going to expand slowly over a period of time, and that we call it as mucocele. Right. So remember mucocele as one of the very important differential diagnosis following trauma or following sinusitis in your frontal sinus causing proptosis of the eye. Right. Now let's go to this image. Again, a constant where they keep asking you what is the structure. This is 1, this is 2, and this is 3. So can you label what is 1, 2, and 3? So this is 1, this is 2, and this is 3. So can you all tell me what is this? 1 is the opening of a tube that connects the middle ear to nasopharynx. So it's nothing but your eustachian tube. What is 2? There is a cushion that covers the eustachian tube. What is this cushion called as? Yes, that is nothing but your torus tubarius. And behind that, there is a depression. What is this depression called as? This is nothing but your fossa of Rosenmuller. Very good. The eustachian tubal opening can be covered with a pad of fat, which is called as Osman's pad of fat. So following pregnancy and after delivery, this fat can get resorbed, and there can also be weight loss that can cause resorption of this fat, and they can have autophony. So I hope all of you have understood this image. Look at this image. If they give you this image where a child has unilateral, nasal blockade, and the child is having difficulty in breathing with epistaxis, what should your answer be? Just give me a moment. Yes. So when they give you unilateral, if they give you nasal obstruction, they give you bleeding from the nose, and this is a male, what should you think of? Yes, very good. Amit, angiofibroma is not red. It is not vascular. Angiofibroma will be pale. It is grayish in mass. Okay. So red vascular in a juvenile age group, you should think about juvenile nasopharyngeal angiofibroma. It won't be present in the anterior part of the nose. You can see here it is present in the posterior part of the nose. Right? Okay. So now let's go to the next question. What do you see here? This image is showing to you something very specific. This is an investigation showing to you that this is a barium swallow. So on barium swallow, you're able to see something very important over here. What is it? Yes, there is outpouching of the mucosa, pharyngeal mucosa, through which muscle? Which muscle you're seeing this herniation? There are oblique fibers of thyropharyngeus, and there are horizontal fibers of cricopharyngeus. Between them, there's a triangular area of dehiscence. What is this called as? Yes, this is called as Killian's dehiscence. And when there is an outpouching of mucosa, what do you call it as? Zenker's diverticulum. So this is nothing but your pharyngeal pouch, also called as Zenker's diverticulum. Very good. Now let's go to the next image. These are 4 images of acute tonsillitis. Can you tell me what is the first image? What is the second image showing to you? What is the third image showing to you? And what is the fourth image showing to you? What is the first type? Where there is only redness, there is no enlargement. What do you call this type of tonsillitis as? Yes, this is called as superficial. I mean, it's not parenchymal, okay? There is only redness, there is no enlargement. Then we call it as superficial. In the second one, you're seeing that there is whitish yellow dots on the surface of tonsil. So whenever you've got whitish yellow dots on the surface of tonsil, what will you call it as? Yes, you will call it as follicular. In the third one, you see that the tonsils are not just red, but they're enlarged and meeting in the midline. What will you call this as? Amit, now it is going to be your parenchymal. Okay, and last, you see that there is a whitish membrane on the surface of tonsil. What is this? This is nothing but your membranous tonsillitis. Okay, so I hope everyone got it. Superficial, follicular, parenchymal, and membranous. Let's go to the next image. We are seeing here that there is again a membrane on the tonsil, but it is not limited to the tonsil. It is spreading from the tonsil. It is going to the uvula. It is going to the palate, and it is grayish white. On peeling, the underlying surface will bleed. It is called as a soot membrane. What is it? Yes, this is nothing but diphtheric membrane. I've already discussed the differences. So let's go to the next image. Now you're seeing here that there is a unilateral bulge of tonsil, and this is pushing the uvula to the opposite side. So see here, the uvula is being pushed to the opposite side. You're seeing unilateral bulge of tonsil. What could be your 2 possible differential diagnosis? Yes, either it could be a peritonsillar abscess or quinsy, or either it could be a parapharyngeal abscess. In peritonsillar abscess, you would see that there is no neck swelling. In parapharyngeal abscess, there will be a neck swelling that is present. Right? So I think this image is enough for discussion. Now look at this image. In this image, you're seeing that this is the midline. From the midline, you see that on the side of the midline, there is a bulge. So whenever you see that there is a bulge on the side of midline, what do you call it as? Which abscess? Very good. Midline bulge will be prevertebral. So if you would see a bulge here like this, then it would be a prevertebral abscess. But since you're seeing the bulge on the side of the midline, it is nothing but your retropharyngeal abscess, right? Good. Now let us see. Look, see there is a midline bulge. Now we've already discussed. Quick, quick, quick. What should your answer be? If you see a bulge in the midline. Yes, very good. This has to be prevertebral. Very good, Mukesh. This is nothing but your prevertebral abscess. Okay, now look at this image. You see a whitish dot on the surface of the tonsil. The tonsil is not enlarged. It is not having any infection, but there's a whitish dot because the crypt of the tonsil has got blocked with the debris. What do you call this as? Yes, Sangeeta, you're right. Midline is prevertebral. On the side is retropharyngeal. Good. Yes, this is nothing but tonsillolith. Yes, so this is a tonsillolith. Very good. Now let's quickly discuss the image of larynx, which they can give you a question. What is structure 1? What is this structure 2? What is this structure 3? What is this structure 4? What is this structure 5? Okay, let me write it with yellow. 5. What is this structure 6? What is this structure 7? What are these structures 8? What is this structure 9? Good. First is nothing but your epiglottis. What we see here first is nothing but your epiglottis. What we see here too is nothing but your false chords which lie above the true chord. So these are your false chord which are lying above the true chords. What you're seeing 3 is nothing but your airy epiglottic fold. So you have a fold connecting the arytenoid to the epiglottis. So 4 is your arytenoid and that is connecting to the epiglottis. We call it as the airy epiglottic fold. 5 is nothing but your pyriform fossa, which is a part of your hypopharynx. 6 is nothing but your post-cricoid region, which is again a part of your hypopharynx. And this wall is your posterior pharyngeal wall, right? And then the structure that you see here, 8 is nothing but your true vocal cords and 9 is nothing but your subglottis, correct? So I think everyone is now clear with the larynx and the hypopharynx image. Now look at this image and tell me, this is the most common congenital anomaly of the larynx, and this presents to you with inspiratory stridor at birth, and on examination there is an omega shaped epiglottis. What is it? Excellent. It is nothing but laryngomalacia. Right. So we know this. So we're going to go next. Look at this condition. The child had to be intubated. This child is probably a child who is present between 3 to 5 years of age or a little bit here and there, and is now having redness and inflammation that is compromising the airway, not even allowing you to visualize the vocal cord. What should your answer be? Yes, acute epiglottitis. Now you'll tell, ma'am, in acute epiglottitis, you told we should not examine the larynx and examination is contraindicated. Then how did you take a picture, ma'am? This can be a question. But look, is the child having airway secured by the endotracheal tube? Yes. After securing the airway, you can take the examination of the larynx. But if you do it without securing the airway, the child can enter into laryngospasm and can collapse immediately. So never examine in acute epiglottitis. Now, what is this that could possibly happen in me and has happened in me already once, where because of excessive talking and excessive vocal abuse following multiple recordings in Hindi and English, I got this in RR, and then full course lectures, continuous recordings, and talking leads to this. Yes, very good. This is nothing but your vocal nodule, also called as singer's nodule, teacher's nodule, seen at the junction of anterior third and the middle third of the vocal cord. They are bilateral, they are sessile. Treatment, if they are soft nodules, you're going to wait and watch and give voice rest. If they do not come down, then you're going to do a microlaryngeal surgery. Fortunately for me, voice rest helped and that was enough. Now let us go to the next one. You see here, this next image is showing to you that there's hypertrophic epithelium on one side and there is a depression on the other side, giving a pseudo ulcer or a false ulcer, again happening because of voice abuse or because of reflux. What do you call this at? See, it's not a polyp. For sure, it's not a polyp. Kissing ulcer is right assess. You're getting hypertrophic epithelium, and this is pushing on the other side to cause this depression. What do we call this as? We call this as contact ulcer, also called as kissing ulcer, also called as pachyderma laryngitis. Okay, so this is pachydermal laryngitis. If we were thinking of a polyp, it would be unilateral pedunculated mass, not in the posterior part. This is the posterior part. We would see a polyp again at the junction of anterior 1/3 and the middle third of the vocal cord. Okay, all of you got it? Yes. Chalo, next question. What is this space that you see here? There is a space that is marked. This is your vocal cords. On the sides of the vocal cord, you are able to see a space. So can you tell me what is this space called as? It is on the sides of the glottis. What will you call such a space? Rinke's edema is a space within the vocal cord foodie. So vocal cord will have 4 layers: epithelium, superficial lamina propria, vocal ligament, and vocalis muscle. So between the epithelium and superficial lamina propria, we call that as Rinke's space. It is only here in the vocal cord, but this is on the side of the vocal cord. We call it as paraglottic space. Okay. So we have got a pre-epiglottic space in the front, and we have got the paraglottic space on the side. Okay, so we call it as pre-epiglottic space of Boyer and paraglottic space of Tucker. Got it? So I hope all of you got this, and Rinke space is present within the vocal cord. Now you have an image here showing to you a swelling on the side of the larynx. This swelling is air-filled swelling because we see that on the imaging it is appearing black. So a air-filled cystic swelling on the side of the larynx seen in trumpet blowers, glass blowers, weightlifters because of excessive intraluminal pressure within the larynx. What is it? Yeah, very, very good. This is nothing but your laryngocele. Is laryngocele possibly going to cause death in patients? Yes, because it can obstruct. We have an external one that is present outside, but can we have an internal laryngocele also? Yes, and this can eventually obstruct the airway, resulting in stridor and death. So yes, this is a very important condition that we often miss. Now look at this image, which is a multiple times asked question where the patient is having a permanent tracheostomy. And through the tracheostomy, you're able to see that there is a prosthesis. And whenever the patient wants to speak, he will cover the tracheostomy site so that the patient can get speech or voice. What is this? This prosthesis is tracheoesophageal prosthesis. And when do we put this tracheoesophageal prosthesis? In those patients who have undergone a total laryngectomy, following what? For laryngeal cancer, and then you do this voice rehabilitation with tracheoesophageal prosthesis. What are the 2 types of tracheoesophageal prosthesis that you should know of? The first one is called as Bloom-Singer prosthesis. The second one is called as Provox prosthesis. So I think this should be good enough for you to recollect things about tracheoesophageal prosthesis. So now are you all ready for imaging? Yes, Shreya, I'll take care of that. The corner writing is not visible. I mean, I just missed it. So I think so far, so good about ear, nose, the pharynx and larynx, all going well. Now shall we do some imaging and instrumentation, and that would complete the class. Maybe another 20 minutes. Are all of you okay with it? Quickly give me thumbs up if all's fine with you. Yes. So since everything is going well, let's do the imaging. This image is showing to you occipitomental view where the chin is up. So whenever you have got this chin up position plus mouth closed, then you say that it is the Waters view, and Waters view is the best view for which sinus? Maxillary sinus. But if the chin up is with mouth open, then what will you call it as? Then you will call it as Pierre's view. And in Pure's view, what are we trying to locate? We are trying to locate the sphenoid sinus. So the image is showing to you actually this Pure's view. What you see here, this is your sphenoid. They can give you an image-based question to ask, identify this. This is nothing but your maxillary. They can ask you this. This is your frontal. Here on the medial side would be your ethmoidal, and open mouth will show you the sphenoid sinus. Good. Now look at this chin down position, asking you to identify pathologies of a particular sinus in the forehead. So whenever the chin is down, we call it as occipitofrontal view, which is the best view to identify frontal sinus pathologies. Of course, we can identify maxillary sinus, ethmoid sinus also, but it is best for your frontal sinus. Now, this is an imaging for lateral view where we try to identify the pneumatization of the sinus, which is nothing but your sphenoid sinus. They can give you an image asking you what is this structure. It is nothing but your frontal. Sandwiched between the frontal and sphenoid are your ethmoidal air cells. So I think that is also done. Now, this is a CT scan showing to you the paranasal sinuses. Here we are asking you to identify some pathologies. So if you look at this, what is this first pathology that I have marked in purple? Can you tell me what is the first pathology marked in purple? Second pathology, you're seeing something that I mark in green. What is this? Yes. And third is an anatomical structure which gives this beak-like appearance, which I've marked in white. Or maybe I can take another color to mark it. Purple. I mean blue, sorry. What is it? Yes, so the first one is nothing but deviated nasal septum, which is curved or bent towards the right side. Now, the second part that you see, this is your inferior turbinates on both the sides. Inferior turbinate on right, inferior turbinate on left. This is the middle turbinate on right, and this is the middle turbinate on left. See, the right side doesn't have any air-filled swelling, but the left middle turbinate has got air-filled swelling. That we call it as a concha bullosa. So, 2 is nothing but your concha bullosa. Right. Third one, this is a beak-like appearance coming from an artery that comes from the orbit, enters the ethmoidal air cells and goes to supply the septum. So which artery comes from the orbit, which is a branch of the ophthalmic artery? Can you all recollect? Can you all recollect? Internal carotid artery gives rise to ophthalmic artery. Ophthalmic artery divides into two arteries. Which are the two arteries? Anterior ethmoidal and posterior ethmoidal artery. So the artery that you're seeing here, 3 is nothing but your anterior ethmoidal artery. Simple, done. Now let's go to this image. They have marked the structure here. So normally the ethmoidal air cells, you see here, these are the ethmoidal air cells which are present in relation to the medial wall of the orbit. But you see there is one air cell which is present in relation to the floor of the orbit. What is this cell called as? Very good. This cell is nothing but your Haller cell. Great. Now let us look at this image. There is some fracture here in the floor of the orbit, and the orbital contents or orbital fat is herniating into the maxillary sinus. And this sign, we call it as a teardrop sign. Where do we see this teardrop sign? Yes, this is seen in blowout fracture of the orbit. All right. So blowout fracture of the orbit produces this teardrop sign. Next, you're able to see here, there is a sign where there is a mass probably coming from the maxillary sinus and going posteriorly into the choana. And there is a column of air between the posterior pharyngeal wall and the mass. What do you call this sign as? Yes, this sign is called as dot sign, also called as crescent sign. And this is seen in which condition? This is seen in anterochoanal polyp. Right. Now look at this image. This is first image showing to you the normal appearance of the pharynx and the airway on a lateral X-ray of the neck. And the second image is showing to you some pathology. So what is this? See, this is your prevertebral soft tissue shadow. And this prevertebral soft tissue shadow is basically showing to you the hypopharynx leading to the esophagus. And here you see an air column. This is your larynx. Larynx is leading downwards to the trachea. Now you see the prevertebral soft tissue shadow over here. Is it increased? Yes. More than 2 times the size of the body of vertebra? Yes. Is it also having sometimes air bubbles within it? Yes. So what should your diagnosis be? It should be nothing but your very good. I see everyone answering it right. It is retropharyngeal abscess. A prevertebral abscess can also present like this. It's further imaging on a CT scan and clinically integrating it with your appearance as a midline swelling or on the side of midline. We assess whether it is a retropharyngeal abscess or a prevertebral abscess. Right? Now, this is another very stand-up image that you could see in almost every examination where they give you this sign of a child where we have given a clinical description already prior. Inspiratory stridor can collapse, can obstruct the airway, presents to you with difficulty in breathing, 5 to 7 years of age, dysphagia, drooling of saliva, but there's no change in voice. What is this condition? It is acute epiglottitis. And in acute epiglottitis, you get a sign. What is this sign called as? This sign is called as thumb sign. Very good. Again, a standard question. This is the normal appearance of an anteroposterior view X-ray showing to you the airway space. You see here the airway is compromised at the level of subglottis, resembling the steeple of the church. And this sign we call it as? Yes. This we call it as steeple sign. Okay. So I'm sure that this steeple sign everyone know is seen in croup. Good. Now this is an image showing to you a foreign body X-ray. In the anteroposterior view, you cannot tell it is in the airway or the digestive tract. You will have to take a lateral X-ray. If you see, this is the airway tract, which is the column of black air, and behind that we have got the prevertebral soft tissue shadow. So where is the foreign body lying? Is it in your airway tract or in your digestive tract? It is in your digestive tract. So hypopharynx leads to upper esophagus. So the foreign body is at the upper esophageal sphincter. This image we have already discussed. Larynx on the side, if we have an air-filled swelling, what will we call it as? We will call it as laryngo-C. Correct. Now look at this image. This image is nothing but the petrous and the mastoid part of the temporal bone. This leaf-like bone is the petrous bone, and this bone here is the mastoid bone. And if you see here, it is grayish and whitish. But look at the opposite side. The mastoid here is clean and it is air-filled and appears black. And hence we know that on the right side, the patient has got mastoiditis. The middle ear is also having no air as compared to the opposite side. So middle ear and the mastoid are appearing hazy. So it's an image of acute mastoiditis. All right. Now let's look at this image again showing to you mastoiditis. These are various mastoid air cells. And within the mastoid air cells, you see that there is air on the right side. So you can see here it's air. But look at the opposite side. It is not having air, but it is grayish or hazy. And even the septae, one cell to another cell, the septae that are present are broken. It indicates to you coalescent mastoiditis. So what is the diagnosis? It is coalescent mastoiditis. Okay. We've already discussed the cochlear implant. We know this is the external component. This is the internal receiver. What we see here is the electrode array, and then we have the ground electrode. Okay. So I think this is also done. Let us look at this image. So if you see, this is your jugular bulb near sigmoid sinus bulb near the posterior border of the mastoid. And here, this is the jugular bulb. From the jugular bulb on the opposite side, there is no bone present between the carotid and the jugular. Ideally, there should be a piece of bone that you see here, right? This is the piece of bone present between the carotid and the jugular. But here we are seeing that this is the jugular bulb, this is the carotid, and the bone is lost. What is this sign called as? Yes, this is called as Phelps sign, which is seen in glomus jugulare. And this is a sign that is radiological sign seen on a CT. This is again a characteristic MRI that we see here. What is this MRI? I'm waiting for your answers. A typical appearance. What is this appearance? Yes, we call this as an ice cream cone appearance. Seen in what? It is seen on MRI brain with contrast. Seen in which condition? Yes, acoustic neuroma, also called as vestibular schwannoma. So in vestibular schwannoma, you should know about the different nerves that are involved, the fifth nerve, sixth nerve, seventh nerve, 9th and 11th nerves, and about the radiological aspects as well. Less than 3 centimeters, you do radiosurgery. More than 3 centimeters, you're going to do surgical excision. Then you can see here there is a foreign body in the nose, and usually if you see this sign where there is a ring around the foreign body, we call this sign as double ring sign, which indicates that it is a button battery. So button battery is extremely dangerous because it releases the alkaline material within it to result in liquefactive necrosis of the tissues around. Now look at this image. You are seeing that there are areas which are light gray and areas which are dark gray. It is not black, it is not air filled. This is all disease, but within the disease also some are light gray and some are dark gray, giving you double density sign. So double density sign is seen in which condition? Yes, it is seen in allergic fungal rhinosinusitis, and you should be able to recollect Bent and Coon's criteria for allergic fungal sinusitis, where serum IgE should be elevated, KOH should be positive, there should be mucin, allergic mucin in the nose and polyps, and there has to be CT scan evidence of double density sign. So all of that is your Bent and Coon's criteria for allergic fungal sinusitis. Now, what is this air cell that is present within the sphenoid sinus, which is an extension of posterior ethmoid into sphenoid and can have optic nerve within it? So what would you call this cell as? Very good, Abhishek, Lavanya. This is called as your Onodi cell, which is the posterior ethmoidal cell extending into the sphenoid sinus. Now look at this investigation. There is a breach in the bone, and you can track the dye coming from the cranial cavity going through this breach into the nasal cavity. So this is a CSF that is stained with fluorescein, and then we track the fluorescein through the defect in the bone that is present between the nose and the sinuses and the brain above. What is this investigation called as? Very good, Shadi. This is called as CT cysternography. And CT cysternography is done to identify active leaks. So for active leaks, we are going to do this CT cysternography. It's not the investigation of choice, but it is the investigation of choice for identifying where active leak is happening. Then we have a few instruments to discuss. Last 5 minutes more, and I'll just leave you off. This is nothing but your Bull's lamp. And this is nothing but your head mirror. This is basic instrument that you require for examination. It's a convex mirror, and it is necessary to focus the light on the area of interest. To magnify and to visualize, we have got an otoscope to visualize the tympanic membrane and the external auditory canal. To do a Siegelization and to increase the pressure in the external auditory canal, we have got a Siegel's attachment, which will help to increase and decrease the pressure in the external auditory canal. The instrument here that is used for syringing, for doing caloric test, is nothing but your Simpson's oral syringe. So the name is called as Simpson's oral syringe. It is used for removal foreign bodies which are non-hygroscopic, button batteries, non-living objects, and even insects you cannot remove with the syringing. But if it is simple wax or it is simple non-hygroscopic foreign body, of course you can do syringing and remove it. Next is your Jobson horn probe with a curette. So Jobson horn probe with a curette is used for removing the wax, for palpating any mass in the canal to identify it is soft or firm in consistency. And you can also do oral toileting with the serrated edge which is present on the other end. The instrument here that is used for making a hole in the tympanic membrane to release the pus or fluid is called as the myringotome. There are different types, but the one that we commonly use is called as the Politzer's myringotome. Okay, and then in patients with SOM, along with myringotomy, we insert a ventilating tube, and this ventilating tube is nothing but your grooming. We should know, very importantly, for our mastoid surgeries, we definitely require mastoid retractors. We require drill to drill the bone, which can have different types of attachments, like a cutting burr, like a diamond burr, and a coarse burr. That is not very important. So whenever you have a retractor, very, very important is to identify the blades. So whenever you see there are 4 prongs on one side, 4 prongs on another side. So if it is equal prongs, 4 by 4 or 3 by 3, what will you call it as? You will call it as Mollison's self-retaining hemostatic mastoid retractor. So what is it called as? Mollison's self-retaining hemostatic master retractor. But if it is 4 prongs on one side and only 3 prongs on another side, so if it is 4 by 3, then we call it as Wheat-Lanner's retractor. Okay, so what do we call it as? Wheat-Lanner's retractor. If we have equal number of prongs, but one prong is longer than the rest of them, then what will we call it as? Then we will call it as Plester's. Because it has got a longer prong, we call it as Plester's retractor. Okay. And if we have a retractor where there is only one prong on another side and 3 or 4 prongs on another side, then we call it as a Perkins retractor. Okay. So I hope all the retractors are done. Now identify. I have given the description. I'm showing you the image. You see 1, 2, 3, 4 on one side, 3 on another side, but one prong is longer. What is this retractor? I've told you longer. What should be the name? Yes, it is your Plester's retractor. Perfect. Look here. There is one prong that is there on one side and 3 prongs on another side. What will you call this retractor? I've discussed this also. Yes, very good. This is called as your Perkins retractor. Excellent. And if it is 4 by 4, what will you call it as? And 4 by 3, what will you call it as? I've already discussed, just a revision. 4 by 4 is Mollison. Reverse M, what do you get? W. It is Wheat-Lanner's. Done? Yes. What is these speculums? These are used for rhinoscopic examinations. The first one that you see is called as the Killian's nasal speculum. The second one that you see here is called as the Thudicum's nasal speculum. This has got a self-retraction blade which you don't need assistance or don't need to use your hand. Once you fix it, it remains open, whereas Thudicum's requires you to have it. This instrument that you see here is called as St. Clair Thompson posterior rhinoscopic mirror. So what is it called as? St. Clair Thompson posterior rhinoscopic mirror. It has got a bend. If there's no bend, then we call it as a indirect laryngoscopic mirror. So no bend would make it an ideal mirror. Bend would make it a posterior rhinoscopic mirror. Then we have got Hopkins rod telescopes or endoscope. So this is called as Hopkins rod, which is nothing but your endoscope with which we do our endoscopic sinus surgery, endoscopic ear surgery, laryngeal examinations, and so on. Now, the instruments that I'm discussing with you are for tonsillectomy. This is nothing but your Boyle-Davis mouth gag. And this Boyle-Davis mouth gag can have different types of tongue blades that are attached to it. So this is your tongue blade that is attached with a slot, without a slot, a flat, and there can be different types of tongue blades that could be attached to this. This is fixed on a stand. This is called as the Draffin's bipod. So once you fix it on the Draffin's bipod, it needs a support below. And that the plate on which it supports is called as the Meg-Oren's plate. The image, unfortunately, I couldn't keep it, but it's your Meg-Oren's plate. So mouth gag, Draffin's bipod, and the Meg-Oren's plate. Then this is your Mollison's tonsillar dissector and anterior pillar retractor. So this is tonsillar dissector and anterior pillar retractor. Okay, this is used for dissecting the tonsil from the tonsillar bed. And once you have dissected the tonsil, you want to cut it with this snare that is present. This is called as the Eaves tonsillar snare. Right? So these are the instruments that we use for tonsillectomy. For adenoidectomy, we use this curette, which is called as St. Clair Thompson adenoidectomy curette. So what is the name given? St. Clair Thompson adenoidectomy curette. Yes. And whenever there is a bleeding, we use two instruments. One is a curved artery and the second one is the straight artery. This is nothing but your straight artery forceps, which is used to hold the bleeder first when it is bleeding in the tonsillar bed. And then you hold the artery again with a second artery, which is called as the Nagus second artery. And then you put your knot and then you release this arteries. So yes, with this, we finish all the instruments, most important ones, of course, and we finished radiological important images and pathologies. We finished all clinical images of descriptions for ear, nose, and throat. Overall, these were about 104 images that I've discussed in about 80-90 minutes time. And I hope you guys enjoyed this session with me. It was a very quick session. I didn't want to go into the depths of each thing because it just confuse you more and it'll take a long time to revise. But this quick session, if you watch it at a 1.5x speed or 2x speed just before the exam, you'll cover it in 40 minutes. And the most important flashcards are in front of your eyes and you wouldn't make mistakes in your exams for sure. So with this, if there's any doubt, please let me know in the chat box below. And I know one doubt is always going to be there that, ma'am, what about the PDF? The PDF will be shared with all of you very soon. We will put it up on the comment section below a few hours after the session because it needs a little bit of processing and I have to send it to the team and then the team will upload it there. And if there's any query, please feel free to reach me out. And I'm always available for any of your doubts or any of your queries, be simple or very difficult. Yes. Okay, so sigma Frios versus Kilian. So if this is the nose, if on the caudal margin at the caudal end, at the last end of the nose, if you make the incision, then we call it as Kilian's incision. But if you make 4 to 5 millimeters behind it, then you call it as a Frios incision. Okay. So Fudi Baha is used in unilateral SNHL because if one side there is a hearing loss and you apply Baha on this side and the opposite ear is healthy, what will Baha do? It will take the sounds from the diseased side and via the bones of the skull, it will transmit to the opposite cochlea and from there the sounds will go to the brain. That is why Baha is used in unilateral. But if both the side there is a SNHL that is profound, both the cochlea are not functioning, then Baha will capture the sound, but further from cochlea, it will not be able to transmit. In such a situation, we have to put an implant within the cochlea. Okay. Suvarna, Rinne and Weber are quite easy. Rinne positive, Rinne negative. You should know positive is seen whenever the patient is normal or has an SNHL. Rinne negative is conductive hearing loss. That is something that you should know basic. Second thing is Weber's test is central or equal distribution of sound on both the sides, and conductive hearing loss, it goes on the disease side, and sensorineural hearing loss, it goes to the opposite side. There's a little bit of theory that I've discussed. If you can go back to my RR or the main video, your concepts will get clear and you will never forget this explanation that I've given to you. Sangeeta, the trick for laryngeal paralysis, maybe I'll make a short video and post it on PrepLadder's Instagram or YouTube channel. But for now, it's not going to be possible to explain that because it's a little lengthy thing that I need to explain because I need to make the points clear first. And then we have 6 combinations: unilateral RLN, bilateral RLN, unilateral SLN, bilateral SLN, unilateral combined and bilateral combined. So for that, I will make a short video and give it to all of you. Yes, so I think second artery, MBBS life. See, first artery, if I hold it and I'm taking an end-on view, I can't pass my knot directly from a straight artery. But from below, if I have a curved artery, I release the straight artery. I put my knot against the curved artery forceps, and I can see whether the artery, whether the tie has gone beyond the artery or not, and then I can remove it. That's a technical question. That's it. That's a technical easiness to do or not. If you have to do straight end on, it's hard. But if it's a curved and you can see your knot is going beyond the curved artery forceps, and you can be sure that now you can release it and it won't bleed. Okay. So yeah, so with this, we stop the class here. I will see you all again and catch you all. If there's any query, do reach out to me. Thank you and bye-bye.